Hi everyone, Becky Hosey here again, reporting on some really cool things I learned. The session that I watched was on fatigue, pain, and opioids. And actually, I'm going to break it up into two videos because all the information is so important, but I don't want to overwhelm you just in one long one. So I'll either record another video today or tomorrow. Really, as soon as I saw this title of the session, I knew I had to watch it. So pain and fatigue are seriously underappreciated in our patient population. And I also have an interest because I have over 10 years of clinical experience working in interventional pain medicine. So I have a bit of knowledge on this as well. The first presenter was so fascinating. She's a rheumatologist, and she started the talk by saying how many times her patients have reported to her that the fatigue and pain are worse than, say, like joint swelling or other symptoms. And she also noted how these needs are largely unmet in our patient population. A study in the US on RA noted that the most impactful symptoms were fatigue at 82% and pain at 76%. And sadly, in this study, only 26% of these patients were actually satisfied with their RA treatment. Multiple studies suggest that fatigue is actually the number one and pain number two most disabling symptoms, regardless of whether the condition is inflammatory or non-inflammatory. So that was quite interesting. The presenter went on to explain why fatigue and pain are so underappreciated. And really, it's that providers they can't see fatigue or pain, right? So they can see like joint deformities and they can see swollen fingers and toes and everything, but they can't see fatigue or pain. And she also noted she thinks there's a lot of underreporting by patients. So patients are not telling their providers about these symptoms, either because they don't think that the provider will understand, or maybe they just think, oh, it's part of this disease, or they have difficulty explaining the symptoms. Another issue that she discussed was that there's no really clear consensus of a definition of fatigue in medicine. It's really subjective and it's really complicated, and it has various subtypes. And she talked about two main categories: physical fatigue and psychological fatigue, right? So we know the physical fatigue, this low energy, this muscle weakness, which she described as jelly legs, and the psychological fatigue, the brain fog, the cognitive things, the weariness. And of course, these types can occur together. They can occur in combination at the same time, or come back, leave, return another day, all types of things. Interestingly, the idea of better controlling the disease and the fatigue will get better has actually not been shown in clinical studies. Multiple studies show the opposite. So one in particular was a presentation that showed over 60% of patients with RA, psoriatic arthritis, and spondyloarthritis who reported fatigue even though they had really low disease activity. So their disease was really well controlled. They still reported fatigue. So switching gears to pain, there are accepted definitions of pain, but it's certainly not uncomplicated. But pain is really an unpleasant sensory and emotional experience. And this is a personalized experience, right? It's influenced by our biology, our psychology, social factors, things that have happened to us. And studies show that pain doesn't always equal inflammation. And studies with patients with RMDs who complain of pain, even when in remission, show that they still have residual pain, even though the inflammation is low and there's optimal treatment. One presenter said that while medicine has done a really good job of blocking pathways for inflammation, coming up with medications for these, there really has been a poor outcome for studying and treating pain. The three main pain categories: nociceptive pain, which arises from actual or threatened tissue damage. So these are of non-nerve tissues, and the activation of nociceptors. And one presenter she said, this is pain as it should be, an alarm telling you there's something wrong. And examples of this are tissue damage, joint inflammation. Neuropathic pain arises due to nerves being affected. And a lot of times, and not all the time, but it can follow a dermatomal pattern, which is just a fancy term for meaning like how does the nerve actually distribute? So where do you feel it? So for instance, you could have a nerve issue in your back and not have any back pain, but you could have, a numb foot. So, and, a lot of times this type of pain responds pretty well to like locally targeted treatments like nerve blocks and such like that. Nociplastic pain arises from altered nociception, but without clear evidence of actual or threatened tissue damage. So like more ambiguous. One presenter called it a volume control problem or amplification issue. And it's usually a global problem, which means that it's like widespread. And one presenter noted it's not just affecting pain, but also sensitivity to light, to hearing, right? I'm sure a lot of us have that as well. So examples of this are migraine headaches, fibromyalgia. Pain reported by patients with rheumatic disease is also often in combination. So not just one type of pain, right? So we get multiple and they're combined and they evolve over time. And there was a new study which was just published earlier this year, which was so really interesting, that looked at patients with RA who had low inflammation. It looked like their disease status was pretty stable, like well controlled. And they said, let's look at their joint fluid, right? Let's pull out fluid from their joint and just look at it. So they actually found a certain gene module, which had, 800 different combinations. And they said that was pretty consistent in all the subjects. And they took these cells and put them in culture in a lab, and the cells actually grew new nerve endings. So this was so interesting. And again, that's really all the information I have on it, because that's all really the presenter noted. But something I want to mention, because I think we'll be hearing about that in the future, so at different conferences. This same presenter also noted that studies show JAK inhibitors tend to improve pain better than some of the other biologics like TNFs. And she said again that traditional lab tests or even assessment tools like looking at swollen joints may not be reflective of the amount of pain a person is experiencing. A term, co-culminant fibromyalgia, was mentioned, and this basically means that there's a significant amount of fibromyalgia that occurs in RMD patients, particularly inflammatory rheumatic diseases. And studies show that this happens about 20% of the time, and really, like the general public, about 2%. So something to really think about. One presenter talked about primary versus secondary fibromyalgia. And this basically has to do with which nerve pathways are affected. And she didn't say the symptoms are different in any one or worse in any one type, but she did say that if the provider can figure out which pathway is the culprit, there are different medications which could be more effective for one than the other. So that was pretty cool. There is a high rate of being diagnosed with fibromyalgia in the first 12 months of being diagnosed with a newly discovered inflammatory disease. And then also traditional inflammatory markers like CRP, ESR, that didn't predict the development of fibromyalgia. Going back to pain and fatigue, it looks like the research suggests if you live in a wealthy country, you're more likely to experience pain and fatigue than those living in a lower income country. And of course, this could be due to societal pressures on the individuals, in that patients in wealthier nations tend to really have higher health expectations. So that was pretty interesting. There are steep consequences for the medical underappreciation of fatigue and pain, including the delay of diagnoses, impacts on quality of life, negative mental effects, anxiety, depression, isolation, reduced work productivity, burden on the healthcare system, society. Really, awareness needs to be raised among patients and healthcare providers, and multiple presenters said this. We have to educate both communities on this prevalence and the significance of fatigue and pain, and there needs to be an open communication between providers and patients. And really, that providers should not just be focusing on your swollen joint or traditional lab tests, but really to incorporate comprehensive tool assessments in clinical practice regarding fatigue and pain, that these are really vital components of your overall health and need to be considered. So in medicine, we call these PROMS, or patient-reported outcome measurements. So hopefully your providers are doing this with you. These factors should really lead to a tailored treatment plan, which will be different for everybody. And that plan should be made along with the patient. And some of the treatments might be medicines, but others like physiotherapy or cognitive therapies or other interventions should also be considered. So there's a lot. And that's what I wanted to share with you today. Yes, I will have another video on the remainder of that presentation, which was just so fascinating. Again, I'm so excited to share this with you, and thank you for watching, and I will see you soon.